Let me introduce myself. My name is Lourdes Martinez, and I'm a partner director at Garfunkel Wild. And I'm here with my partner, Michael Stone, who's also a partner. I run the Compliance Regulatory Defense Group at Garfunkel Wild, and Nick has joined us from his 10-year tenure at the Department of Health, where he was the point of contact for legal issues with respect to adult care facilities, home care agencies, and also with licensure of hospitals and nursing homes. So let me tell you a little bit about Garfunkel Wild, and then we'll go right into our very timely subject of emergency preparedness. Garfunkel Wild was founded, I think it was either 36 or 38 years ago, with the purpose of attending to the business and legal needs of our clients in the healthcare industry. We have 4 offices, one in Great Neck, one in Albany, one in Hackensack, and one in Connecticut. And we are consistently ranked Tier 1 in healthcare by Chambers. So let's go right to our topic of the day, which you're all nursing homes on this webinar. So there's not one person here who doesn't know of the tragedy in Florida, in where 8 people, 8 residents, died in a nursing home in the aftermath of Irma. So this is very timely, especially in light of the fact that there are new regulations, the new emergency preparedness regulations. These are federal regulations which went into effect last year with an implementation date of November 15th of 2017. So we have about a month and a half, 2 months perhaps, to get ready and make sure that we are in compliance with these regulations. Being in compliance with these regulations are a condition of participation for both Medicare and Medicaid. And I anticipate that with the recent tragedy in Florida, that this will be something that the state and the federal government will certainly be looking at when they come to survey our facilities. So having emergency preparedness is not something that's new in the nursing home industry. So it was already required by the federal government, and it certainly has been required by the New York State government. But that doesn't mean that just because you are in compliance with the regulations as they used to be, that you're done and that you're all good. As a matter of fact, there are significant changes in these regulations, and there are more stringent requirements. So it's something that we have to pay close attention to, particularly in the next 2 months, so that we're actually ready by November 15th. The Emergency Preparedness Program, the regulations define it as the facility's comprehensive approach to meeting the health, safety, and security needs of the facility, its staff, the patient population, and community prior to, during, and after an emergency disaster. So what are the steps that we have to go through? We need to have a plan. Sorry, I didn't slide. We need to have a plan. We need to have policies and procedures. We need to communicate the plan, and we need to train our staff. But not only train our staff, we have to test the plan that we put in place to make sure that it works. I'm sure you were all reading the same newspaper articles that I was reading about what happened in Florida, and one of the issues there was that the generator was either not working or insufficient. So would testing the generator have changed that? I don't know, but it's something that we need to do. We need to test the program. Okay. We're going to go into the specifics of what the regulations require, but first let's just go through kind of a checklist of what it is that the nursing home has to do in order to be in compliance. So the first thing we have to do is have a facility-based risk assessment and a hazard vulnerability analysis in order to comply with the new requirements. So what are the risks? What possibly can happen in our nursing homes? Is it a hurricane? Is it a blizzard? Is it a flood? Is it a power outage? Whatever it is, we need to identify that as part of our risk assessment. There also needs to be a community-based risk assessment, or the nursing home, if there's already a community-based risk assessment, can adopt that risk assessment from other agencies. So first you have the risk assessment, then you have to put together the plan. So we need to draft and revise, if you already have one, the facility emergency plan, and it has to be based on the risk assessment that you had already undertaken. After that, we need to do policies and procedures of how we're going to handle the particular emergency. What are you going to do for the residents? What information are you going to have readily available to transfer with the residents if you have to send the residents out of the nursing home? What are you going to do if the computers are down? What staff will you mobilize? You need to have all of this in your plan based on your risk. You need to draft a communication plan that includes the contact information of what staff members and or volunteers are you going to mobilize, how are you going to communicate with those people, what happens if the phone lines are down, what happens if you don't have cell service. So we need to have that in our communication plan. How are we going to provide information about the patient? I'm sure you all read that a lot of family members were saying in Florida they were trying to call and they didn't know if their family members were alive or not alive, or sick or okay. So how are we going to communicate the information about our residents? We're going to need to develop a training plan for the staff, contractors, volunteers. We're going to need to train them. We need to document the training and make sure that they actually understand the training, which, in my opinion, requires more than just, 1 or 2 training sessions a year. The more you train somebody, the more they'll understand it. There needs to be a full-scale community-based training exercise, or if you can't do it in the community, depending on where you are, then it will have to be a facility-based exercise. So what does that mean? That means you pretend you're having the emergency and you mobilize staff and see how it is that they're going to react to it. Sometimes that's called a tabletop exercise. Once you do this, you have your training, you're doing the exercise to see if the training has actually worked. Then you're going to have to assess what worked, what didn't work, and you're going to have to revise your plan as necessary. And the revision of that plan may very well include additional training or using different people depending on what the situation was. So let's get right to the risk assessment now. So that was kind of like our checklist. Now let's talk about the risk assessment. What is the real question here? What could possibly happen? That's the question. What emergencies could we foresee happening based on the weather, our own facility, shortcomings, the world around us? What are the issues that could come up? And then, once we've identified those, what are we going to do if it actually happens? How are we going to keep the residents safe? So the regulations tell us that an emergency plan must be based on, actually this is in the State Operations Manual, based on and include a documented facility-based and community-based risk assessment using an all-hazard approach. What is an all-hazard approach? It's an integrated approach to emergency preparedness that focuses on identifying hazards and developing emergency preparedness capacities and capabilities that can address those as well as a wide spectrum of emergencies or disasters. So what does that mean? It means you have to look at everything: a natural disaster, a man-made disaster, a facility emergency. It could be care-related, it could be an equipment or power failure-related emergency, a cyber attack, interruption in communication, loss of a piece of your building or a portion of your facility, and interruption in getting essentials like food and water. So really, the list could be endless as to, what the possible emergencies could be. So the all hazards planning focuses on developing capacities and capabilities that are critical to prepare for a full spectrum emergency. So the first step, again, is to identify what hazard can occur. Now, the all hazards planning, thankfully, because we're all human, does not mean to address every possible threat, but it is meant to ensure that the facilities will have the capacity to address a broad range of emergencies if the unfortunate circumstance one day happens. And that last bullet is just a little reminder that consistent with former regulations, elopements are considered an emergency. So I know that for the most part, we all have what to do in an elopement. That's a plan that we have down, but I just wanted to remind you that that is also an issue. Okay, so let's talk about the risk assessment. There needs to be a process for the assessment, and we need to document what the potential hazards are and how they're likely to impact the facility. So, if you're in a geographical location that there's never ever been a hurricane, then obviously you're not going to plan for a hurricane, but maybe you'll plan for some other natural weather event. So it has to be specific to your geographical region, to your community, and to your resident population, which changes obviously from nursing home to nursing home. So do you have a population that's largely ambulatory? You're going to deal with your emergencies in one way. Or do you have a vent unit, a TBI unit? All of those factors are going to affect how you do your risk assessment. So part of the risk assessment is to identify what are the gaps in my facility. Obviously, in Florida, one of the gaps was either the generator wasn't working or wasn't working well enough. So that's a gap that needs to be identified. Okay. Facility-based is the part of the emergency preparedness program that's specific to you, but that doesn't mean that you're not going to look at the geographical location, but you will look in the facility who your residents are, as I said before, what type of facility you have, what are your surroundings? Are you in a rural area? Are you, like they said about this nursing home in Florida, are you across the street from another hospital? Are you in a location that you can get help quickly, or is help 20 miles down the road? Continuing with the risk assessment, the community-based risk assessment is an attempt to, this is from the State Operations Manual, to afford the facilities the flexibility in deciding which healthcare facilities and agencies it considers to be part of its community. So they do not give us a definition for what your community is. They're giving us the flexibility to make the decision as to who we're going to use in the community, who is our community. It could be, other entities within the state, a multi-state region. It really will depend on where you're located. You may rely on the community-based risk assessment developed by other agencies, such as a public health agency, an emergency management agency, and a regional healthcare coalition. However, that does not mean that you're not going to have to do your own facility-based risk assessment. It means you can incorporate it and you can use it in the facility-based risk assessment. So generally, these are just some factors that are used in developing the risk assessment. And these are really, it's a list of things that you should consider and decide whether these are issues that are within your own facility, within your own location. So number one, what business function is essential that you keep in operation during an emergency? Well, the obvious answer to that is care. So we need to maintain a level of care to either get our residents through the emergency or get our residents evacuated to another facility. So obviously that's the most important one, is the care of our residents. But think about risks and emergencies that you may have to confront, contingencies for which the facility should plan for, again, your location, assessment of the natural or man-made emergencies that could cause limit to your nursing home's operations, and what arrangements could be necessary. Do you have facilities close by? Is there a hospital close by if we needed to move our residents out in an emergency situation? So now we've gone through the parade of horribles and the litany of what are the things that can happen in our nursing home. So step two is, what are our strategies? What are we going to do about this if one of the potential emergencies that we have already identified actually happens? So some of the strategies that we need to consider, and some of the items are staffing. What are we going to do? How are we going to have enough people in our facilities so that our residents are safe? What are we going to do if we have staffing shortages? What are we going to do if, for some reason, and I know this happened a lot during Sandy, some facilities took in extra residents, so you needed to have extra staffing in order to care for the residents that actually came in. So we need to do this for each hazard or each emergency that we identified. And we need to have key people that are responsible for executing the plan for each emergency. And we need to define what the key people's responsibility are and the other staff members. We also need to have sufficient supplies and equipment to sustain operations for 3 to 10 days based on the risk assessment. 10 days is a long period of time if you're thinking about food and water and possible power outages. So that's something to certainly keep a focus on. So the emergency plan must address the resident population. It must be specific to your particular population. Who's at risk in your population? How are you going to provide for those people in the emergency, and how are you going to continue operations, if that's what the plan is? Okay. So Again, the emergency plan must specify the population served within the facility. The whole purpose is to make sure, or the main purpose, is to make sure that your residents, that your staff, that your volunteers, that your people are safe and are able to we're able to maintain their safety throughout the emergency, whatever it is. Okay. So in continuing operations, right, in our emergency plan, a continuity of operations, the plan must address the type of services that we're able to provide in an emergency. And if we're not able to provide it in an emergency, we must have a plan to evacuate those particular residents. We must have the staff who's going to be primarily in charge, who's going to be able to direct the other staff. And there should be somebody who's authorized in writing to act in the absence of the administrator or ownership or somebody else who, maybe the director of nursing, who's responsible for the operations of the facility. So there has to be some kind of succession plan in case the administrator can't be there or the director of nursing can't be there or there's some type of issue. We need to have this succession plan. We need to figure out who's essential, who is the essential personnel, what are the essential functions, obviously giving care, what critical resources do you need, what vital records and IT data protection do we have. If we have to evacuate residents and they're going to a hospital or they're going to another nursing home, those other care providers, those receiving facilities, are going to have at a minimum these people's names, the list of medications they're on, their diagnoses. So we're going to need to figure out how we're going to transport that information with the residents so that they get the care that they need at the new facility. These are just some resources for you. CMS advises that facilities should refer to and use the FEMA resources. So we gave you some websites there. So the emergency plan must also include cooperation and collaboration. So what does that mean? Include the process. The plan must include a process for cooperation with local, tribal, regional, state, and federal emergency preparedness officials, efforts to maintain an integrated response during a disaster or emergency situation, including documenting of efforts to contact officials, and when applicable, if its participation is collaborative and cooperative planning efforts. That kind of stands out at me as I read it, because again, going back to the tragedy in Florida, there's a disagreement as to, well, there's different accounts, I should say, as to whether this particular facility where the 8 residents died actually reached out to try to get help, or whether they actually didn't reach out to try to get help. So, like in everything in healthcare and everything in compliance, documentation of what your efforts are is very important, and it should be contemporaneous documentation. And last but not least, before I turn this over to my partner, Mick Stone, the emergency plan must be reviewed and updated at least annually, according to the Fed, but twice a year, according to New York. So let me turn it over to Mick Stone.
Thanks, Lourdes. So before I get started on going through the policies and procedures, I just wanted to give a reminder that this is going to be available. This webinar is going to be available on the Garfunkel Wild YouTube channel, and an email link is going to be sent to the registrants within the next coming couple of days or so after this presentation. So if I'm speaking too fast, you can watch it on YouTube and slow it down. Also, on YouTube, I should also mention that we also have a webinar on the Phase 2 implementation of the long-term care regs as a whole. I just wanted to point out too, when we're talking about the risk assessment, that's actually part of the facility-wide or the facility-based assessment that you'll have to do and have in place by November 28th, I believe, is the date that the part 2 of the implementation for the long-term care regulations goes into effect. Okay, so policies and procedures. So the emergency preparedness policies and procedures must be developed and implemented in accordance with emergency plan. So you're using your plan, again, I think as Lourdes mentioned, as the basis for crafting your policies and procedures. It's also it's also going to involve your communication plan too, which is what we're going to get to later on. So first of all, probably most important, your policies and procedures are going to need to address the subsistence needs of your residents in the facility. And actually not only them, but staff as well. And I think if you're expecting that you may have to shelter other people within the community, that too. So this is going to include obviously your food, water, medical and pharmaceutical supplies. And then also you're going to have to provide alternate sources of energy. That's typically going to be your generator to maintain temperatures to protect patient health and safety, and for the safe and sanitary storage of provisions such as refrigeration. And also emergency lighting, fire detection, extinguishing alarm systems, which I believe was specifically mentioned in the old regs, and also sewage and waste disposal. So food, water, medical, and pharmaceutical supplies. You must be able to provide for adequate assistance for all patients and staff for the duration of emergency, or until all patients have an adequate and operations. So residents part of your operations. There are no set requirements or standards for the amount of provisions to be provided in facilities. Obviously, that's going to be dependent on your own risk assessment in terms of alternate sources of energy. So you're not required to upgrade electrical systems, but after review of your risk assessment, you may find it prudent to make any adjustments to ensure that occupants' health and safety needs are met and that facilities maintain safe and sanitary storage areas for provisions. So again, no hard, fast rule on upgrading your systems or what your electrical requirements might be. It's all going to be dependent on your risk assessment and what your facility is going to need in the event of a hazard. So it's also up to each individual facility, based on this risk assessment, to determine the most appropriate alternate energy sources. Again, generator and the amount of capacity that generator is going to have. And actually, I'm going to get more into that later when we get to the emergency power regs, or portion of the regs. But they must be in compliance, or must the sources must be in accordance with local and state laws, as well as life safety code requirements. And that actually isn't new. So if you already have a generator, you're already supposed to be compliant with the NFPA 99-100-110.
Just to go back for a second, though, about something that you said before, Mick, that I just want to throw out that maybe people, nursing homes want to consider, is to take a look at how long a supply you currently keep of the residents' medications, because that might be something that you may want to just change on a going forward basis, depending on what it is that you're doing right now. So I didn't mean to interrupt, but I just wanted to throw that out there.
So your Continuing on with the alternate sources of energy, your policies and procedures must determine how required heating and cooling of the facility will be maintained during an emergency situation and or as necessary if there were a loss of the primary power source. Obviously, not just during the emergency situation, but afterwards. I suppose you could say that after the actual event, if you still have power out, that you're still within the emergency situation. So, and again, obviously, you're thinking about the Florida situation. You have to maintain an adequate system for emergency lighting, fire detection, extinguishing, and alarm systems. This is also required under the physical environment regs, which are at 483.90. So again, that's part of the general long-term care regulation overhaul that I referred to before. With respect to on-site sewage treatment, it's not required. I think they considered it, CMS that is, but discounted it when it was clear it was not possible for facilities. But policies and procedures should reflect maintenance necessary services and steps to be taken to prevent, for instance, food contamination and other sewage or waste-related health hazards. And obviously, you know, whatever those, steps that you're going to be taking, they still have to follow EPA and state regulations as well. So with respect to sewage and waste-related health hazards, you know, you have to consider, you want to consider the treatment of your soiled linens during the emergency. How's that going to happen? Disposal of biohazards, and of course also, for instance, I guess more to the line of provisions, access to your to medical gases that might be required. Policies and procedures also involve providing for a tracking system. So you have to have a system to track the location of on-duty staff and residents in the facility's care during and after an emergency. If those residents are relocated during the emergency, or if the staff are, the facility must document the specific name and location of the receiving facility or other location. That information needs to be readily available, accurate, shareable among officials within and across the emergency response systems. A facility that is using electronic database should consider backing up its computer system with a secondary source such as hard copy documentation. You're not required to track the location of patients who have voluntarily left on their own or who have been appropriately discharged, but obviously, goes without saying, it should be documented in the patient's medical record that they have voluntarily left on their own or have been discharged. And with respect to electronic tracking systems, again, just as a reminder, New York has an e-find system that probably most New York facilities are participating in. With respect to evacuation, your policies and procedures have to address how you're going to do that, and must include consideration of the care and treatment needs of evacuees, the staff responsibilities, transportation, identification of evacuation locations, and primary and alternate means of communication with external sources of assistance. So you should also consider the evacuation protocols for not only patients, but for the residents, but also the staff members and family and resident representatives or other personnel who sought potential refuge at the facility. So facilities must consider the patient population needs as well as their care and treatment. So if an evacuation is in progress and the facility must evacuate, leadership consider the needs of critically ill patients to be evacuated and accompanied by staff who could provide care and treatment en route to the designated patient site. And that's in the event that trained medical professionals are unavailable by the transportation services. So that, again, when talking about the resident population, again, that's another reflection back to your facility-wide assessment that you've done. So CMS is going to expect that you have a good idea of who you have in the facility and what those needs are. And with respect to transportation, you have to consider the equipment that might be available when deciding to whether you can evacuate a particular resident safely. If your resident is event dependent, is the transportation capable of handling event dependent resident? And does that have the staff for that too, if your staff isn't available? So to that end, you're considering triage systems for evacuees. You have specific staff members responsible for making those triage decisions. And again, back to one of the points the board has made, you're going to want to have, I guess, a line succession or a succession plan in case that particular staff member is not available. So you're also going to want to consider the communication of patient care to the intaking facility, attaching hard copies of the standard abbreviated health condition or history, the injuries, allergies, and treatments rendered, as well as family or representative contact information. So you must outline the primary and alternate means for communication with external sources for assistance, e.g., for example, your primary means might be your regular telephone system, but you're going to need an alternate in case that telephone system is out, which might be satellite phone. And again, also back to triage, you might want to, in terms of suggestions on how you might want to prioritize, and it may be dependent on the particular disaster and whether or not you're going to evacuate some patients or all of them. But the prioritization might consider the acuity of the patients, their mobility, and the location of where you're going to be transferring them to. And with respect to sheltering in place, the procedures must address, and this is from the reg, a means to shelter in place for patients, staff, and volunteers who remain in the facility. So you're looking at when it's more appropriate than evacuation to stay in place, how you're going to make sure that your policies and procedures are in alignment with your risk assessment. You're looking at your structural stability. How likely it is that your building is going to be able to survive intact from whatever the disaster might be, and continue to function both during and after the emergency. And also, and to that end, your facilities are determining, your policies and procedures are based on the type of emergency and the type of patients, the staff, volunteers, visitors that may be present during an emergency. So again, based on your plan, the facility could decide to have various approaches to sheltering some or all of the patients and staff. So you're considering whether it's too dangerous to shelter or to shelter your residents or evacuate your residents, or whether it's too dangerous to evacuate particular residents or to shelter particular residents. And, so with respect to your medical documentation, so obviously you're going to be preserving that throughout the emergency. So that includes your patient information, and you're still obligated to protect the confidentiality of the patient information and secure and maintain the availability of records. So this is one thing they stress, that this is in addition to existing requirements for patient records that are found in existing laws. And these policies and procedures must be in compliance with HIPAA as well. So you're not excused from HIPAA in the event of an emergency, although I think we'll get to where HIPAA does make some accommodations for you, but that's within HIPAA, not HIPAA. So you're required to ensure that patient records are secure and readily available to support continuity of care during the emergency, as Lourdes was pointing out before. Your use of volunteers. The use of volunteers in an emergency or other emergency staffing strategies must be provided for in your P&P, including the process and the rules for integration of state and federally designated healthcare professionals to address surge needs during an emergency. So any necessary privileging and credentialing processes must be included in the policies and procedures to allow those volunteer healthcare professionals to be able to perform services, of course, within the scope of their practice and training. more on the use of volunteers. You have flexibility in determining how best to use volunteers during an emergency, as long as the use is in accordance with state law, state scope of practice rules, and facility policy. Your volunteers may include federally designated healthcare professionals, such as public health service staff, national disaster medical system, medical teams, Department of Defense Nurse Corps, Medical Reserve Corps, and as well as state-established volunteer registries, such as SERV-NY in New York. The emergency plan must include a method for contacting off-duty staff during an emergency and procedures to address other contingencies in the event staff are not available to report to duty, which may include, but are not limited to, using staff from other facilities and state or federally designated health professionals. Arrangements with other providers. So you have to have developed arrangements with other long-term care facilities as well as other providers to receive residents in the event of limitations or cessation of operations at your facility to maintain continuity of services to long-term care residents. So this would include your prearranged MOUs or transfer agreements with other providers to ensure continuity of care. And you should also have prearranged agreements for transportation as well. The policies and procedures also must consider the possibility of an 1135 waiver declaration. That's referring to Section 1135 of the Social Security Act. That's declared emergency by the Health and Human Services Secretary, also the President, I believe, in the provision of care and treatment at an alternate care site identified by emergency management officials. So you're expected to collaborate with your local emergency officials in planning to allow an organized and systematic response to assure continuity of care, even when services at their facilities have been disrupted. So again, you know, your coordination efforts have to take into account when 1135 waiver is declared and whenever it is. And you know, 1135 waiver would allow you, for instance, to maybe operate at an alternate site, that sort of thing. So your policies and procedures updates, the regs require, the federal regs require that they be reviewed and updated at least annually and revised as necessary. You know, as necessary, again, might include if your facility-wide assessment shows that your patient population has changed significantly, or if you've experienced an emergency event. So that might be occasions where you need to look at the policies and procedures as part of an after-action review. New York requires the emergency plan, which includes your procedures, to be updated at least twice a year. So.
Before we go to the communication plan, I think the one big takeaway that you should all have from these, I'm going to call it the first two sections, the emergency plan and the policies and procedures, is that this is not going to be a one-size-fits-all for all of the nursing homes. So nursing home A could be a brand new state-of-the-art facility with a lot of, you know, emergency contingencies already built in, and the nursing home next door, B, could be in a 100-year-old building, which is going to make a huge difference in what your emergency plans are. So it has to be individual to you and not just an off-the-shelf type of compliance program.
And so now moving on to the communication plan. Again, it specifically references that it's got to be developed in accordance with federal, state, and local laws. So that's respecting how you're doing that. So the communication plan must have the names and contact information for staff, entities providing services under arrangement, residents and physicians, and other long-term care facilities, as well as volunteers. So the guidance suggests that it may be prudent to have contact information for facilities that are not long-term care facilities as well, but that's not specifically required. So it's what makes sense for you. Facilities have discretion in the formatting of this information. However, it should be readily available and accessible to leadership and staff during an emergency event. So again, again, no specific prescription on how you're supposed to do it, just that it's readily available and accessible to leadership and staff.
And not to interrupt you again, but the really difficult part here with this communication plan is going to be with staff turnover. So with the staff turnover, we're going to have to remember and say, gee, we're going to have to go back and we're going to have to update our list and update our communication plan, which is difficult to do when you're running around doing everything else that you have to do. So.
And then also you're using electronic data storage, or assuming that you are, you should be able to provide evidence of data backup with hard copies, or demonstrate the capability to reproduce contact lists or access this data during emergencies. So information must be accurate and current, obviously, and again, that goes back to the staff turnover issue, and also any other changes in the information that might occur throughout the year. Sources of assistance, that's your contact information for your local governmental entities, emergency preparedness staff, your state licensing entity, the long-term care ombudsman's office has to be in there as well as any other sources of assistance that are applicable to your risk assessment. Your facilities, again, you have discretion in formatting this information as well, and again, has to be available to leadership and staff. You're encouraged to do it in electronic format also, as well as hard copy format as well. So the means of communication. This has to be provided for in your communication plan. So again, it's expected that you would consider things like, again, this is within your discretion, and it might depend on where you're located. If you're in a rural area or that might not have access to or reliable access to cellular phones and that sort of thing. But also, you're looking at radio transceivers and ham radios maybe. So that all should be provided for. The communication plan needs to include procedures regarding when and how those alternate communication methods are used and who uses them. So you need to ensure that the selected alternate means of communication is compatible with the communication systems of other facilities, agencies, and state and local officials. So obviously, those people you're looking to contact, you should ensure that whatever alternate means you have chosen also works for them as well. Guidance suggests that you seek information about National Communication System, which offers a wide range of national security and emergency preparedness communication systems. And I would just point out, this is from the state operations manuals. They're suggesting that you look into these and include them into your plans. It's a good idea, obviously, to do so. If it works for your facility. With respect to information on patients, the communication plan must include your method for sharing that information, the medical documentation for your residents, as necessary with other healthcare providers to maintain continuity of care. The means in the event of an evacuation to release resident information as permitted under HIPAA. A means of providing information about the general condition and location of patients under the facility's care is permitted again under HIPAA. So your communication plan, and again, with respect to your information on patients, you have to ensure that the information necessary to provide patient care is sent with the evacuated patient to the next care provider would also be readily available for patients being sheltered in place. Timelines, again, not specified, but facilities are expected to provide patient care information to receiving facilities during an evacuation within the time frame that allows for effective patient treatment and continuity of care. You should not delay patient transfers, of course, during an emergency to assemble all those patient reports, tests, etc. So that obviously patient safety is the concern. Making sure that all the documentation follows is secondary. So you won't let that tail wag that dog. So Again, more information on patients, no particular means for sharing the information, whether paper or electronic is specified. You do have to have a communication system in place that's capable of generating timely, accurate information that could be disseminated or permitted under HIPAA to family members and others. And again, HIPAA requirements are not suspended, but under HIPAA, there are requirements for disclosing patient information as part of disaster relief efforts, and also for notifying family members of patient's location and general condition. Your communication plan also has to include a communication of the facility's needs, as well as the facility's own ability to assist, for instance, other facilities or the community at large. So you have to have a means of providing information about your occupancy, the needs of your residents, as well as the critical needs of the facility's operations, and the facility's own ability to provide assistance to the authority having jurisdiction or the incident command center or designee in the event of the emergency. Obviously, you should consider how your occupancy affects your ability to provide assistance. You should consider the type of needs that your facility might have during an emergency and would be able to communicate to the appropriate authority. But those needs obviously should include, but are limited to, if you have a shortage of medical supplies, assistance, and as well as assistance with evacuation and transfers. No particular means is prescribed, again, but facilities should include in the communication plan a process to communicate the required information. So local, state, tribal, federal emergency preparedness officials, as well as regional healthcare coalitions, can assist in the identification of their incident command centers and reporting requirements depending on emergency. So obviously include that in your communication plan as well after reaching out to them. And sharing information with residents and patients, it must include a method for sharing that information from the emergency plan the facility is determined as appropriate with residents and their families or representatives. You don't have to share the entire emergency plan, obviously, with patients and residents, but information about that plan, about what's going to happen in the event of emergency, and how your decision-making is going to work, that obviously is something that you would share with residents and resident representatives, can be provided. CMS recommends that you provide a quick fact sheet, so it can take that form, as a fact sheet or an informational brochure to the family members and resident or client or resident representatives, which would highlight the major sections of the emergency plan and policies and procedures deemed that you, the facility, would deem appropriate. And again, it has to be updated, reviewed and updated at least annually. I would say, as long as you're reviewing and updating your plans, in New York, again, you have to do it biannually or twice a year. You should also, I would think that it would be safe to assume that your communication plan would be considered part of your emergency plan for that purposes, and should be updated at that time as well.
Just on this next section, Mick, I just want to point out that this training and testing program, to me, is the highlight of all of this, because I can have the most beautiful emergency plan, I can have the best communication plan, the best written policies and procedures, but if I haven't trained my people and if I haven't tested the program, then it's really all for naught. So I just wanted to, I don't want to say it's the most important part, but it's up there. So go ahead, I'm sorry.
Right. Yeah, I mean, that's, and really, you'll have the documentation to show the surveyors, but they're also going to want to talk to you staff and see what their, see how familiar they are with the documentation of the policies and procedures in the plan. So, Obviously, that training testing program is developed in accordance with your emergency plan, your risk assessment, your policies, procedures, and communication plan. So it all goes together. You must provide initial training in emergency preparedness policies and procedures to all new and existing staff. Your individuals who are providing services under arrangement, volunteers, all consistent with their expected roles. You're providing emergency preparedness training at least annually. And you have to maintain, of course, documentation of the training. I think as attorneys, we always have to say document. So make sure you've done that as well. And you have to be able to demonstrate staff knowledge of the emergency procedures. Just to be clear, training refers to the facility's responsibility to provide education and instruction to ensure that all individuals are aware of the emergency preparedness program. You're required to have a written training program on emergency preparedness policies and procedures that you can show surveyors. Individuals who provide services on a per diem basis, such as agency nursing staff, or provide on an intermittent basis, would be expected to assist during, and who would be expected to assist during an emergency, must also receive that emergency preparedness training. With respect to your initial training, facilities provide initial emergency training during orientation or shortly thereafter to ensure that the initial training is not delayed. So obviously you want to do that training as soon as possible.
But I have to underscore that that's not enough, because during the orientation training, most people are being trained on 20, 30 subjects, infection control, compliance, emergency. So there needs to be a follow-up training in order for there actually to be real comprehension of what to do in this emergency. I'm sorry, go ahead.
Okay. So the annual training, it should be, I think what we're looking for is it would be modified each year to incorporate any lessons learned from recent exercises, any real-life emergencies that might have occurred in the last year, and also during your annual review of the facility's emergency program. So, you'll have to, obviously during your annual training, if the annual training is the same from year to year, you might want to ask yourself why that is and whether or not you're incorporating everything that you should be into it. The facility has discretion to decide what level of training each staff member will be required to complete each year based on that individual's involvement or expected role during an emergency. So there is some flexibility there. And depending on the specific staff duties during an emergency, the facility may determine that documented external training is sufficient to meet some or all of the facility's annual training requirements. But obviously, there has to be some sort of documentation that that staff has underwent that external training. And so documentation must include the specific training completed as well as methods used for demonstrating knowledge of the training program. It's going to likely be based on the training delivery method, so however you conduct it, whether as an exercise, writing, that sort of thing. So evaluation or written exam. So, so with respect to testing, so this is testing the training that they've already gone through. So you're going to be conducting or participating in exercises, including unannounced staff drills, using the emergency procedures to test the emergency plan at least annually, including participation in a full-scale community-based exercise or a facility-based exercise if community-based exercise is not available. And again, if you can't get that full-scale community-based exercise and you have to do just the facility-based exercise, you should document your attempts to conduct an annual community-based exercise.
And just, this is someplace that Mick and I and Garfunkel can actually help you, particularly in the tabletop exercises. Mm-hmm. So what does that mean? That means we come up with the parade of horribles for you, and then we can assess, how the facility handles it on a going forward basis.
Right. Yeah. So the tabletop exercise, that's, you're still required to do the full-scale community-based or the facility-based if not possible, and then so you have to do a second additional exercise. And then tabletop becomes an option for that too. So
Exactly.
there's no getting around the actual exercise.
Exactly.
But the tabletop is an alternative for the second one. And you must analyze and document the facility's response to the drills, exercises, emergency events, revising the emergency plan as needed. In New York, particularly requires staff drills in accordance with the written emergency plan at least twice a year. So it's if you're already complying with New York law, you're kind of doing that now. More testing. So just for, I guess, as a definition, it's the concept in which training is operationalized and the facility is able to evaluate the effectiveness of the training as well as the overall emergency preparedness program. So that includes conducting drills or exercises to test the emergency plan, to identify your gaps and areas for improvement in your plan. So a full-scale exercise is defined as any operations-based exercise, so your drill, functional or full-scale exercise, that assesses the facility's functional capabilities by simulating a response to an emergency that would impact the facility's operations and their given community. So it's also an operations-based exercise that typically involves multiple agencies, jurisdictions, and disciplines that are performing functional or operational elements. The tabletop exercise, which we referred to, so that's going to involve your key personnel that are discussing the simulated scenarios that Lourdes said that we could provide in an informal setting. So the tabletop exercise can be used to assess plans, policies, and procedures. So it's going to be discussion-based, and it could also involve elected or appointed officials and other key decision-making personnel. And it's going to be centered on, a particular hypothetical scenario. So, one of the benefits, obviously, of it is that you don't have to deploy your resources in order to do the tabletop exercise. So you're expected to consider your physical location, agency, and other facility responsibilities and needs of the community when planning or participating in these exercises. And you're expected to document the date, the personnel, and the agency or healthcare coalition that you contacted in attempting to participate in full-scale community-based exercise. And again, so if, as I said before, if you're not able to identify a full-scale community-based exercise, and again, there's resources out there that you should be able to leverage. So there's the ability to document attempts, and so it's likely that you will be able to, again, depending on the geographic area. But document your attempts, and then hold on to that documentation for no less than 3 years, according to the regulations. And so the whole purpose of it, you're trying to figure out your lessons learned. So you're doing your after-action review process to develop an actionable after-action report. So you're going to want a discussion that includes leadership and identify and document lessons learned, as well as the necessary improvements that you need to make. So your AAR at a minimum should determine what was supposed to happen, what actually occurred, what went well, and what the facility can do differently or improve on, and a plan with timelines for incorporating those necessary improvements into your emergency plan and policies and procedures and communication plans necessary. So an actual emergency event or response of sufficient magnitude that requires activation of the emergency plan meets that annual exercise requirement. So see, we're a little over time, so we're going to hustle through the rest of this. But and again, the training and testing programs has to be updated, reviewed annually. And we'll just move on to emergency and standby power systems. So you must have emergency and standby power based on the emergency plan. Obviously, if you have life support systems, in the guidance there's even some, I guess, lack of clarity about whether or not you're required to have a generator necessarily, that you might, for instance, based on your own risk assessment, decide you don't need one. However, if you have life support systems that are used for your residents, you have to have a generator, and that comes from the Physical Environment Regulations and 43.90. So the use of emergency power systems in long-term care facilities should include consideration for design to accommodate any additional electrical loads the facility determines to be necessary to meet all subsistence needs required by emergency preparedness plans, policies, and procedures. So that's what we've already determined in our plan. With respect to generator location, it has to be located in accordance with the location requirements found in the healthcare facility codes. So we're looking at NFPA 99, NFPA 101, NFPA 110, and this is when a new structure is built or when an existing structure or building is renovated. So assuming that a generator is required for your facility, you'll have to comply when building a new facility or when renovating your existing facility with, I believe they're mostly found in NFPA 110 with the generator location requirements. And again, all these life safety code, the NFPA, that's all incorporated by reference into these regulations, so they essentially have the force of regulation. Those standards do, which actually they refer to as code now. The emergency standby power system care inspection and testing, again, that's in compliance with the maintenance requirements in the code, the NFPA, life safety code, as well as with, in the instruction manuals for your particular piece of equipment. And with respect to fuel, you have to have an on-site fuel source to power emergency generators and have a plan on how it will keep emergency power systems operational during an emergency unless, of course, you're evacuating. This includes maintaining fuel on-site to maintain generator operation, making arrangements for fuel delivery for an emergency event. If the fuel is to be delivered during an emergency event, planning should consider limitations and delays that may impact fuel delivery. Hopefully, what happened during Katrina, I think, in Mississippi, I think a fuel truck that was designated for nursing homes generators was actually commandeered by state authorities. Hopefully, that won't happen anymore. If the facility plans to evacuate during the emergency, a sufficient amount of on-site fuel should be maintained to keep your emergency electric or energy system operational until the building is evacuated. Okay, one thing that I'll just point out that we did not address as part of the regs is the requirements with respect to integrated healthcare systems. That's basically, involving if your facility is part of a healthcare system, the requirements there. The reason why I did not, or we did not include it in this presentation was you're still going to be required to do things on a facility-by-facility basis. So although it might be a resource that works for you to do integrated systems, it's optional. If you're a part of a system, you don't have to do your emergency planning based on that. But just note that if you are part of a healthcare system and the healthcare system is doing it, you're not excused. You still have to have a facility-specific plan. And so I think we had left a slide for questions and answers, but I don't think so.
So we'll just, if you have any questions that we didn't have enough time to answer, what we'll do is we'll just email you the answers or we'll give you a call. We have your contact information. So thank you very much for attending the webinar. Have a great day.